Okay, well, the important thing about my conflicts of interest is the bottom line here, that I have no major stock holdings or ownerships, and that's why I'm still full-time academic at Columbia. Or maybe that's because I'm full-time academic at Columbia. So now we're going to talk about how to treat lupus nephritis in 2016. And we'll go through some key questions, and we'll go through the things that there are clear answers to and others which there are not so clear answers to. We'll start with a case. This is a 33-year-old African-American single stock analyst with an 8-year history of lupus. She has no symptoms. She's on hydroxychloroquine and prednisone, 5 milligrams a day. She goes on a Caribbean cruise, gets sun exposure, develops arthralgias of her fingers, swollen ankles, and a 12-pound weight gain. Her blood pressure on coming in is 150/92. She has a malar rash. She has 2 to 3 plus pedal and pretibial edema, and she has swollen PIP and MCP hand joints. Her urinalysis shows 3 plus proteinuria, 3 plus hematuria, and RBC Cas. You know she has active glomerulonephritis. Her creatinine is 1.6. Again, for a 33-year-old, it's way up. Anti-DNA double-stranded antibody is positive. She has a low C3 and a low C4. So her biopsy shows diffuse proliferative lupus nephritis. Here you see a biopsy with every glomerulus markedly proliferative here, and it would have full house staining for immunoglobulins, and you'd see subendothelial electron-dense deposits. Question 1. What is the recommended induction therapy for this patient? Should we use mycophenolate 2.5 to 3 grams a day for 6 months? Should we use IV cyclophosphamide? Should we use mycophenolate plus rituximab? Should we use either mycophenolate or IV cyclophosphamide? So let's look at the data. You're going to get your chance at answering the questions with the audience response system on the next lecture. But for this one, let's just look at the data. Both the American College of Rheumatology and KDIGO recommend the same thing. For induction, you can use mycophenolate and steroids for 6 months, or cyclophosphamide and steroids for 6 months. You could use the Euro-Lupus regimen, low-dose cyclophosphamide, 500 milligrams given every 2 weeks IV for a period of just 3 months, or you could use the high-dose 0.5 to 1 gram per meter squared once a month for 6 months. Either regimen is acceptable by both boards here. And some people would actually use oral cyclophosphamide, though it's certainly the minority in this country. If you get mycophenolate and you're induced in it and you're improved, fine, you go on to maintenance. If you get mycophenolate for 6 months and you're not improved, you go over to the cyclophosphamide arm. If you get cyclophosphamide and you're improved, you go to maintenance. If you're not improved, you go to mycophenolate. So again, you're looking at 2 alternative regimens. One is first line, one is second line, but the first and second line are up to you because, again, the data isn't clear as to which is better. Where does this data come from? So from a number of clinical trials that have taken place over the last 5 to 10 years, nothing more than 10 years ago. So I'm going to call this the Ginsler study because Ellen Ginsler was the first author. She's a rheumatologist at downstate New York, and she really pushed this through with the FDA supporting it. It's a study of 140 patients with severe lupus nephritis. If you look at mycophenolate given for 6 months versus IV cyclophosphamide monthly, based again on the NIH regimen, a big dose every month for 6 months, both with the same dose of tapering steroids, complete remissions were more common with mycophenolate. Partial remissions, more common with mycophenolate. Complete and partial remissions, more common with mycophenolate. So if you looked at this, you'd say, hey, mycophenolate seems to be superior. Now, this was a study that was designed to be equivalent. Moreover, there are a number of flaws in the design of the study. Even though, I was involved and the Columbia group was involved, we were the last center to join. We couldn't change the protocol. I mean, it was a crossover design. It's amazing that she got this into the New England Journal. So we then did a follow-up study. The follow-up study was the ALMS trial. 370 patients now, not 140, worldwide, not just in the United States. Half get allocated to mycophenolate for 6 months, half get IV cyclophosphamide for 6 months, both with the same dose of steroids. We look at the responders in this group, and if you responded, you went on to the maintenance phase that we'll talk about in a few minutes. When you looked at the responders between mycophenolate and IV cyclophosphamide for 6 months, there was no significant difference. Now, this was based on decline in proteinuria, stabilization of the creatinine, clearing of urinary sediment, all of the things that you might want in renal function. They were identical at the end of 6 months. So, oops, let me go back one there. So, given that, you might say, well, if they're identical, why did so many people switch over to mycophenolate? Because people felt if you had 2 studies showing that mycophenolate was equivalent to IV cyclophosphamide, it's a more benign drug. Most of us had had a long enough experience with cyclophosphamide, either orally or IV, that we were worried about the toxic side effects long-term of the drug. Now, that's one regimen, mycophenolate. What about the cyclophosphamide? The Euro Lupus trial was going on at the same time. It was multicenter, prospective, only had 90 patients, not 300 and something, but it looked at standard NIH doses of IV cyclophosphamide, 0.5 to 1 gram per meter squared for 6 months monthly, and then 3 months later a dose, 3 months after that a dose, versus low dose IV cyclophosphamide. 500 milligrams every 2 weeks for just 3 months, followed by oral azathioprine. This is their low-dose Euro-Lupus regimen. The initial follow-up was less than 4 years. Subsequently, they have a longer follow-up. And this shows you the 10-year follow-up. If you looked at higher doses of cyclophosphamide versus lower doses switching to azathioprine, which many people would feel is a much more benign drug than an alkylating agent, the patients equivalently were free of end-stage renal disease over time. So they did very well with this regimen. And if you looked at the creatinine at 10 years, it was 1 in the high-dose group, 1 in the low-dose group. 24-hour proteinuria, 0.6 grams, 0.5 grams. Many of the patients needed ongoing glucocorticoids or other immunosuppression. Well, of course, I mean, this is a 10-year study. People with lupus flare over time and they wax and wane. The important issue was that at the end of 10 years, the total amount of cyclophosphamide, including all relapses that the high-dose group had gotten, was 9.5 grams. It was only 5.5 grams in the low-dose group. Now, if you're thinking about things like fertility, bladder problems, etc., that's very important. If you're thinking about things with long-term tumors, it's even more important to keep the dose of the alkylating agent low. So that's the Euro Lupus trial, and indeed, that captivated a lot of people. The big issue was, though, Euro Lupus was done in Europe, and it was done on a Caucasian population. Everybody asked, can I apply that in the United States? If I have a white college student at Columbia University and they get Euro Lupus, maybe they're going to do fine. But what if I have a black or Hispanic college student at Columbia? Can I use that data? Now, later I'll show you some evidence that you actually can. But in any case, that's what was done here, and the Euro Lupus trial became one of the possibilities that you can use. Now, if we go back to our 33-year-old African American with this flare of lupus, what should we do for maintenance? Let's say we give her some therapy with either cyclophosphamide or mycophenolate. Should we use every 3rd month IV cyclophosphamide pulses for up to 2 years, which was the older NIH regimen? Should we use continued mini pulses of 500 milligrams of IV cyclophosphamide? That is the Euro Lupus initial regimen. Should we use mycophenolate for up to 3 years, azathioprine for 3 to 4 years, or either mycophenolate or azathioprine for at least 1 year or more? So the answer is going to be the last of these. And again, both the American College of Rheumatology and KDIGO recommend the same thing. If you get mycophenolate induction and you're improved, you either go on mycophenolate at a lower dose or azathioprine, and you continue this for some period of time. If you got cyclophosphamide induction and you did well at the end of 6 months, you either get mycophenolate or azathioprine. Remember, if you don't do well with this, you get cyclophosphamide. If you don't do well with this, you get mycophenolate. But again, the maintenance is either of those drugs. Now, why is that? Well, the first study that really suggested that you would do better than the older regimen, which used every third month continued cyclophosphamide, was Gabe Contreras' study from Miami. Very small study comparative to the others. It only had 60 patients, actually 59 patients. If you treated people with 6 months of Cytoxan and then put them on maintenance because they were doing okay, if they continued getting every third month cyclophosphamide, they had a much higher rate of mortality or chronic renal failure than if they got azathioprine or mycophenolate. If you look at freedom from relapse, it was lower with continued cyclophosphamide than azathioprine or mycophenolate. If you looked at hospitalization days per patient year, it was worse in the cyclophosphamide group that kept getting cyclophosphamide. Amenorrhea was a third of the patients versus 6 or 7% with the oral agents. Infection was much higher, and even major infection, though there are no asterisks, it's not significantly higher, but it's clearly worse with continued IV cyclophosphamide. Now, this is in 2004. Virtually everybody switched over to using azathioprine or mycophenolate for maintenance, based on the fact that the older regimen with cyclophosphamide was less effective and more toxic. There have been 2 studies that have come out since then. One is the ALMS maintenance trial. We said that in the ALMS trial with the 370 patients, if you got mycophenolate or IV cyclophosphamide for 6 months and you were doing well, you got re-randomized for maintenance for 3 years to either mycophenolate, 1 gram twice a day, or azathioprine, 2 milligrams per kilogram. If you asked me how these groups were going to do, I would have said they would do exactly the same, because they're both effective drugs. But it turns out, in the 227 of the 370 patients who were doing well enough to get re-randomized, if you look at the probability of not having renal failure, doubling the creatinine, dialysis, etc., the mycophenolate group was significantly better than the azathioprine group. Let's look at the details. Treatment failures with mycophenolate, treatment failures with azathioprine. End-stage renal disease, only azathioprine. Renal flares, higher with azathioprine. Creatinine doubled, more with azathioprine. Rescue medicines needed, azathioprine did worse. Broad definition of doing badly, azathioprine did worse. Everything was in favor of the mycophenolate. Moreover, because this was international and it was a large study, you could look at whites, blacks, Asian, etc., and whoever's left for other, that if you look at treatment failures here, it was always lower in orange with mycophenolate than azathioprine. If you look at the US, Canada versus Latin America versus Asia versus Europe, in every group, the azathioprine did worse. So this is a study where everything leaned over in favor of the mycophenolate. And most important, if you started with 6 months of mycophenolate, because remember, the ALMS trial randomized patients to mycophenolate versus 6 months of IV cyclophosphamide. If you started with induction with mycophenolate and continued on it, you had less treatment failures than if you started with mycophenolate and got switched to azathioprine. If you started with IV cyclophosphamide for 6 months and got mycophenolate, you had less treatment failures than if you got switched to azathioprine. So you might say overwhelmingly in favor of mycophenolate, maybe not overwhelmingly, but certainly in favor of mycophenolate. Now, some people have said, but the Europeans have gotten different results. Yes and no. This is the MAINTAIN trial. So this is a study by Fred Husio and the Euro-Lupus group. What they did is they looked at a population here that they treated them with the Euro-Lupus regimen of the mini doses, 500 milligrams of cyclophosphamide every 2 weeks for 6 doses, and they then gave them either azathioprine or mycophenolate. If you look at the groups here over time, there was no difference in the probability of not having a renal flare. Now, what does this tell us? Well, it's a little tricky, because there are a couple of things that are important. First of all, they didn't use end-stage renal disease or doubling of the creatinine. They used no renal flare. Well, they had to, because I showed you back then at 10 years, if you use a Caucasian population in Europe, almost nobody gets renal failure. They all do well in both groups. So again, you're not going to get a lot of renal failure. You have to do renal flares, a much softer endpoint. Secondly, the renal flare rate was 25% with azathioprine, 19% with mycophenolate. Look at the numbers. There's only 90 patients in the group here. Remember, in the ALMS trial, there were 227 patients. If you look at this difference and you had 2.5 times the number of patients, it would be statistically significant. It may be a matter of numbers, or it may be just the population that you're looking at. Both drugs are effective. If I had to look at a minority population, I'd rather have them on mycophenolate. If you had somebody that you didn't want to use mycophenolate because they want to get pregnant or they can't afford the mycophenolate, even though it's generic, it's still more expensive than azathioprine, then I would say fine. They're going to do pretty well on azathioprine. Bearing in mind that these studies don't have data on minorities, but we'll come to that. Now, just to support that, this is a study from University of Mexico, or Mexico State University, that they've looked at a large population who either gets induced with IV cyclophosphamide or mycophenolate. The mycophenolate maintenance groups here in red and green do better than the azathioprine maintenance groups. Likewise, if you look at maintenance for all their patients, they come out the same again. Perhaps in Mexico City, it's a minority population, maybe it's a Hispanic population, certainly. So maybe that just bears out the fact, again, in minorities, you might do better by using mycophenolate. A little aside about membranous lupus. So membranous lupus, thickened capillary walls here, immunoglobulins, epimembranous deposits, but mesangial deposits as well. We can say a couple of things. I only use vigorous therapy if they have nephrotic range proteinuria or a progressive course, or side effects like DVT, renal vein thrombosis. There's no point in giving very vigorous therapy to somebody with 2.5 grams of proteinuria who's doing well with their membranous, because it's a slowly progressive disease. Steroids, cyclosporin, IV cyclophosphamide, mycophenolate, rituximab, all have been shown to reduce proteinuria in this group. Cyclosporin and tacrolimus are likely to be more effective than steroids alone. That's based on an NIH trial. Mycophenolate and IV cyclophosphamide are equivalent. That's based on the analysis of the ALMS data on this. Jake Radhakrishnan, my partner, did this, and using all the ALMS data. The role of rituximab and ACTH are not defined. Evaluate the patient for potential side effects of each therapy. If they want to get pregnant and they've had a lot of Cytoxan, I wouldn't use it. If they get a lot of GI problems, I wouldn't use mycophenolate, etc. If their creatinine's a little elevated and you're worried about cyclosporin or TAC, I'd be careful. The most important thing with membranous lupus is don't overtreat somebody who's going to have a fairly benign course. It is not diffuse proliferative disease. Again, it's not going to be that progressive unless they have very heavy proteinuria. Now, this is the ISN Renal Pathology Society classification of lupus. And you can see there's minimal mesangial, mesangial proliferative, 3 focal proliferative, 4 diffuse proliferative, membranous, class 6, advanced sclerosing with 90% global sclerosis. There are A's for active and C's here for chronic. I'm going to summarize all of this into just one slide. This is what I look for when I have a biopsy of somebody with lupus nephritis. First, is the biopsy adequate? The more glomeruli you have, the better it is. If you gave a pathologist, if you gave Dr. Renke an entire kidney, he'd say, where's the other kidney? I mean, you can't give them too many glomeruli. But if you have less than 7 on a biopsy, you're making a lot of guesses, especially about focal or diffuse proliferative. For the class, don't treat class 1 and 2, the mesangial ones. Send them back to the rheumatologist. Membranous, we just talked about, only if they're heavily nephrotic. Class 6 Class 6 is not active. It's not proliferative. It's sclerosing. It's all global sclerosis in 90% of the glomeruli. You're very unlikely to change the course. So the two areas that you're treating vigorously are focal proliferative and diffuse proliferative, and only if there is an A with it for active lesions, proliferation, etc., necrosis. If it's AC, it's part both, okay, but if it's all C, it means it's chronic, inactive, it is not to be treated. So 3A, 4A, focal proliferative active, 3AC, 4AC, you treat. Class 4C is just chronic sclerosing. There is no point in treating it. The more chronicity you have, especially interstitial fibrosis, the lower the benefits. But glomerulosclerosis by itself has to be very extensive. Glomerular sclerosis never correlates with the course of the patient as well as tubulointerstitial fibrosis. And that's true of all glomerular diseases. So if you have 75% interstitial fibrosis, that's a bad-looking biopsy. If you have 80% glomerular sclerosis, some of those patients still can go many, many years if you can cut down the inflammation in the remaining of the 20% of glomeruli. Always look, are the deposits extensive by electron microscopy? Two bad findings, fibrinoid necrosis in the glomerular capillaries and crescents are bad findings. I said that before, it's bad in any disease. And a repeat biopsy can give you a lot of information. If you have somebody and you biopsy them, and 6 months later you're not sure whether to keep treating or treat less vigorously, do another biopsy. There's a famous renal pathologist, Gary Hill, who said that if you can only do one biopsy on your patient with lupus nephritis, make it the second biopsy. Because again, you get so much information from that follow-up biopsy. Have they responded or haven't they? So that's 6 rules. I actually showed this at our course a month or two ago, and Dr. Degatti and a bunch of pathologists are in the front row, and they said they actually agree with these. This hones down the whole classification for you. How long do you treat somebody with lupus nephritis? Well, you follow the guidelines for maintenance therapy. Maybe. So why is that maybe? There are a whole series of groups that have looked at the guidelines for treating lupus nephritis. EULAR EDTA from Europe, the American College of Rheumatology, KDIGO, Kidney Disease Improving Global Outcomes, the Spanish Society, the Dutch guidelines, the Juvenile SLE, the Japanese Review, etc. They all look at the data. All of these papers were published, guidelines, in 2012. They had exactly the same data in 2012. They had the Eurolupus data and MAINTAIN, they had the ALMS trial and the ALMS maintenance study. So what are the conclusions? All guidelines recommend mycophenolate or azathioprine plus low-dose steroids. The European groups, EULAR and EDTA, recommend MMF over azathioprine if there's MMF induction and a good response. The Spanish group advises MMF in all patients over azathioprine. A recent meta-analysis found no difference between the groups here. KDIGO said you can use a calcineurin inhibitor and low-dose steroids in people who are intolerant of MMF and azathioprine, and there's no comment in any of those about Rituximab because there was no data. Okay, so now you're saying, well, wait a minute, the groups aren't exactly agreeing here. What about duration? EULAR and EDTA recommend at least 3 years of maintenance. Don't write this down, folks, because you're going to see it's crazy. KDIGO says at least 1 year of maintenance. The Spanish, who are a part of EDTA and EULAR, recommend 2 years, even though EULAR recommends 3 years. All recommend gradual reduction. There is no advice beyond 3 years. And the ACR puts it concisely. To date, there are not adequate data to say how rapidly azathioprine or MMF can be reduced. Given that little bit of confusion, this is what I do. And again, what I do could be wrong, but it works in my patients. It works in New York City. If you're close to New York, you're okay. I favor MMF, especially in minority groups. However, I have no reluctance to use azathioprine. If somebody has a cost problem, if they want to get pregnant and you can't use mycophenolate, use azathioprine. Again, these are factors I'd consider. I favor 3 to 4 years treatment for proliferative lupus unless there are special circumstances. If somebody wants to get pregnant, if they're having problems with side effects. And usually at 3 years, I taper the dose down. If they wanted to get off earlier, I'd still taper the dose. For membranous, as I said before, I'd use a shorter treatment here, and I usually use either mycophenolate or calcineurins. Now, that doesn't mean you have to do this, but this is exactly what I do. Most of my colleagues at Columbia do this. You know, other centers might use something else, but this works in a lot of the patients. Okay. The patient responds to mycophenolate and then relapses, and due to fertility questions, refuses to have cyclophosphamide. She's had it before and she doesn't want cyclophosphamide anymore. What therapy should be used next? Should we add Rituximab? Should we add Belimumab? Should we add Abatacept? Should we use a proteasome inhibitor, Bortezomib, Carfilzomib? Should we add an anti-interferon alpha drug, switch to ACTH, use a calcineurin inhibitor? Whole bunch of different choices here. Well, this is the reason I'm not going to have you vote on this one, because I think we drive everybody crazy if you had to vote on this, that any of these is potentially possible, but some are better than others. So this is the LUNAR trial. Now, you already heard before that Rituximab did not work in actually 2 trials in lupus. In lupus nephritis, the LUNAR trial is the only large randomized trial. It looked at 140-something patients here. Everybody got the same dose of steroids. Everybody got a full dose of mycophenolate. This group got Rituximab. 2 weeks later, another 1,000 milligrams. 6 months later, 1,000 milligrams of Rituximab. 2 weeks later, 1,000 milligrams. This group got IV normal saline, IV normal saline, IV normal saline, IV saline. So everything is the same, except one group's getting Rituximab, one group's getting saline. When you look at the endpoint in terms of having the response at 1 year, 46% had a good response in the placebo group, 57% in the Rituximab group. Now, there's a problem with that. It is not statistically significant. So either you say, well, wait a minute, there's only 140 patients, there should have been 300 and something. Well, I told the guys, the Rituximab people, that they should have more patients in the study. We wanted more patients, but they said they didn't need it. So it could be a statistical thing, that in fact, in terms of if you had more patients, it would make a difference. Or it could be if you use a full dose of mycophenolate and steroids in this population, Rituximab doesn't add to it, because in the literature, the area where Rituximab has been the best is in treatment failures or people who relapse. That's where it seems to have added the most. So LUNAR does not support the use of Rituximab, certainly as induction therapy. It doesn't say you can't use it for relapses. Now, the reason this is so important is at the Imperial College in London, they've been using a steroid avoidance regimen since 2006. In all new lupus patients, they give them methylprednisolone when they give the Rituximab on day 1 and day 15, and they give them mycophenolate, but they don't give oral steroids with it. This is a no oral steroid regimen. Here's the data on the first either 50 or 75 patients that's published. If you look at complete and partial remissions with this regimen, 90% overall remit. If you look at focal proliferative, diffuse proliferative, or membranous, again, they all do very similarly and they all do well. If you look at the urine protein creatinine ratio, it comes down. If you look at the serum albumin, it goes up. If you look at the serum creatinine, it actually comes down. You may not be able to see the downtrend, but it is definitely down here. So if you look at all of this, these patients did well. And they did well without getting oral steroids. Now, why do we want to get rid of oral steroids? Well, the first thing this lady said when she came into the office, into our glomerular center, was, Dr. Appel, you have to have something other than steroids to treat my lupus. Just, again, as cushingoid as you can imagine. Here's a young guy. Look at those stretch marks here. I mean, it's terrible. This is a guy who was the captain of his high school basketball and football team until he developed lupus and then got treated with this stuff and just had terrible deforming stretch marks all over. And he was treated by a nephrologist, not a rheumatologist. So again, you want to avoid the side effects of steroids. There is the Rituximab trial. The Rituximab trial is a study that's ongoing in Europe. It's, just starting in the United States, 252 patients. They're looking at complete remission, partial remission, etc. Exactly the regimen that I told you. Methylprednisolone only when you get those doses of rituximab, mycophenolate maintenance in between, versus methylprednisolone plus mycophenolate. It's the ALMS regimen here that has steroids versus the same thing without steroids. And there are a number of other trials that are, again, looking at drugs that block anti-CD20. What about belimumab? Belimumab is the first drug approved for treating lupus in 40 years in the United States. So if you look at this, belimumab blocks BAFF and BLISS, and it causes apoptosis of B cells. It prevents antibody production by the B cells that go on to form plasma cells, plasmablasts and plasma cells. So again, it has plausible mechanisms of action. These are the studies that led to its approval in the United States. If you look at response here, a systemic lupus responder index, here is placebo, here is placebo. The placebo, by the way, is therapy for lupus. It's steroids and azathioprine and mycophenolate, all the things you do. Here is, you add on low-dose belimumab. Here's high-dose belimumab. Now, I want to point out a couple of things. One, the systemic lupus responder index includes renal function. It has creatinines, it has proteinuria, etc., but it also has serology, clinical findings. It was specifically designed to see if we could get a drug approved by the FDA. I always say that, I should have been a rheumatologist, because if you look at rheumatoid arthritis, all you have to do is get your patients to walk across the room faster and the FDA approves the drug, whatever it is. In lupus, you've got to get the creatinine down, the proteinuria down, hard numbers. You can't fudge that. So that's why there are 30 drugs approved for RA and nothing approved for lupus. So Rich Furie, who is a rheumatologist, invented this index, and it's worked pretty well. But even so, the response here is modest in terms of improvement. It's not that dramatic at all. So don't think that this is going to change the whole scope of lupus. And these are lupus patients, not lupus nephritis. Is there data in lupus nephritis? Yes, there is. There is a little data. What Marianne Dooley did is she took all the patients who had over 1 gram in proteinuria in those 2 controlled trials that led to its approval. This is the placebo group, low-dose belimumab added to the other medicines these patients are on. Here's high dose. Patients with a renal remission, 58 versus 65 versus 70%. This is time to renal remission was the longest if you got the placebo added on as opposed to the belimumab. It's suggestive enough that there is a trial going on now. We're part of it at Columbia. It's 464 lupus nephritis patients. It's phase 3 because the drug is FDA approved already for lupus, that you get standard of care, which can be IV cyclophosphamide and steroids followed by azathioprine, or MMF and steroids followed by MMF. Either regimen is okay. You add on belimumab on day 0, 14, 28, etc., and every month for 104 weeks versus placebo. And again, there's a second trial looking at belimumab as well. So again, this is a large, controlled, randomized trial. You'll get an answer from this. Now, abatacept, which is known as Orencia for rheumatoid arthritis, that abatacept is a co-stimulatory blocker. It blocks T and B cell communication. So it's been studied in a number of trials with lupus. It has not been successful in these trials of lupus. But there's one study that I'd like to point out. It's being studied in another trial now, but the study I'd like to point out is this one. This study, the ACCESS trial, looked at Euro-Lupus low-dose cyclophosphamide and steroids, followed by azathioprine. Half the group got abatacept added on, the co-stimulatory blocker. Half the group did not. If you look at the response here at 52 weeks, in everybody, placebo actually did better than the abatacept group. Okay, well that's all right. The important issue here is that using the Euro-Lupus regimen, if you look at African Americans here, they did just as well as everybody else with the abatacept. So it turns out there is data on the Euro-Lupus regimen in minorities. Low-dose Euro-Lupus cyclophosphamide works well in a diverse North American population. It's not a ton of data, but it's enough data to suggest, yes, that you can use this. If I have the black college student and I wanted to use abatacept, which is an FDA-approved drug, you could use it if you wanted to. There's just no evidence that it works yet to add on to the other regimen. Proteasome inhibitors, you hear a lot about this when you talk about amyloid and multiple myeloma. Bortezomib and carfilzomib are two that are FDA approved, and there are others that are coming out. There's data in mice. This is the only mouse slide I'll show you for all my talks today. So if you look at bortezomib here, proteasome inhibitor, these are NZB, NZW mice that develop bad kidney disease here. Here, they're getting saline. Here, they're getting bortezomib from week 18. Here, bortezomib from week 24. The groups that get the proteasome inhibitor have a much better survival than the others. They live longer. Well, that's the hardest endpoint you can get, even in a mouse. Moreover, if you look at proteinuria, it stays low with the proteasome inhibitor. It goes up if you use placebo instead. Now, that's mouse data. The problem is that I can cure almost any mouse with lupus that you give me. I have all kinds of medicines. I'm great at curing mice, but curing people is harder than curing mice. And again, there's not a lot of data. This is one study, and there are studies ongoing now. It's 13 lupus patients who had failed cyclophosphamide, MMF, or Rituximab. All of them had active serology, but it improved with the bortezomib. 7 with active lupus nephritis had a decrease in proteinuria and stable renal function. They had no serious adverse events, those that would require hospitalization or mortality, but 3 of the 5 people had polyneuropathy. Now remember, with bortezomib, the trade name is Velcade. You know this from myeloma and everything, that you do get into trouble in terms of polyneuropathy. And the big question is, are newer proteasome inhibitors going to be more useful? The ones we have now, I would limit their use in terms of it's still experimental, but they're available drugs. I'm not going to talk about this. Axar gel, ACTH gel, that's the only brand of this ACTH is what this is, but it's natural ACTH. It's the only one available in the United States, is being studied for membranous lupus by Brad Rovin at Ohio State. We're involved. It's a single-arm trial. Again, it's a pilot project. Since the ACTH has worked in membranous, idiopathic membranous, we're trying it in membranous lupus. And finally, multi-targeted therapy. So if you look at multi-targeted therapy, this is a study, a collaborative study from China. It's a large study. You're talking about here, you're talking about 360 patients here, followed over time. They get mycophenolate, tacrolimus, and prednisone versus IV cyclophosphamide and prednisone. This is their overall response. It's much better with the MMF, the TAC, and the prednisone. Now you look at that and you say, this is very impressive, but then somebody's probably asking, well, wait a minute, all those other studies came out in the New England Journal and the Lancet, et cetera. Why is this in the Annals of Internal Medicine? It's not a bad journal, but why is it there? It's there because even though there's a very good response, that part of the definition of response was decrease in proteinuria. And one arm that's got TAC, if you have a calcineurin inhibitor, you always decrease proteinuria. Cyclosporin or tacrolimus will do that. What people really want to know is not 6 months, but what happens at 2 years. at 2 years, is the multi-targeted therapy going to have better renal results? And they couldn't give us the data. And that's the reason that this eventually was in the Annals and not in the New England Journal or something else. But in any case, I still would point out that there is evidence that adding on something like a calcineurin inhibitor will give you more reduction in proteinuria, and perhaps it is better than steroids plus cyclophosphamide. So what's our treatment of severe lupus nephritis in the future? Treatment will still be divided into an induction and maintenance phase. The induction therapy will consist of cyclophosphamide or mycophenolate. It's usually going to be IV cyclophosphamide. Newer regimens, we may use calcineurin inhibitors, ACTH proteasome inhibitors. Again, all of these medicines are FDA approved. You can use them in your patients now. You just don't have the data from the large multi-center randomized trials yet. The maintenance therapy is certainly going to still consist of mycophenolate or azathioprine, but we may be using rituximab or other agents as well for maintenance, again, as more data comes out. Oops, I did that again, didn't I? And the use of combined immunosuppressive regimens will increase. The most important thing, when you see somebody with bad lupus nephritis, one regimen is not the same. It used to be everybody got IV cyclophosphamide. If you did badly with IV cyclophosphamide, you got more IV cyclophosphamide. If you were a kid and you got IV cyclophosphamide, you got more IV cyclophosphamide. If you had problems in terms of side effects, you got more because that was the only treatment. Now you have options for induction, options for maintenance, and you have these add-on medicines for relapses. The whole thing is cutting down side effects, keeping people in remission longer so they can lead a normal life. We can do much better with lupus nephritis than we could do just a few years ago. When you see this, you've got to think of all those newer agents, but at least for induction, 2 choices, for maintenance, 2 choices right now, based on a lot of data and a lot of large controlled trials coming out. And I'm going to stop here.